Good morning, everyone. My name is Patrick Woody. I'm president of the North Carolina Rural Center, and it's a pleasure to be with all of you today. Welcome to today's virtual town hall hosted by the North Carolina Healthcare Association. Today's program on creating healthier communities is part of a series of town halls that connect North Carolinians with hospital and health system leaders and offer opportunities to hear about some of the challenges, the successes, and the future opportunities for healthcare in our state. Today, we will hear from 5 rural healthcare leaders about how their hospitals and health systems blend medical know-how with community engagement and technology to help prevent and manage chronic conditions and to address factors affecting health like access to healthy food and transportation. We will discuss how they work with their local employers, with schools and faith organizations, and other partners across the community to build healthier and more vibrant communities. Let's meet our panelists. John Green is the president and CEO of Iredell Health System. Todd Hickey is the chief strategy officer for East Carolina University Health. Chris Lumsden is the president and CEO of Northern Regional Hospital. Dr. Penny Burlingame Deal is president and CEO of Onslow Memorial Hospital. And Annie Carpenter is the assistant vice president of Mission Health. First, a few housekeeping items. All lines will be muted throughout the program. If you have any technical issues during the webinar, please send a note in the question pane and we will assist you. Questions may be asked anytime by clicking the Q&A icon at the bottom of your screen, and we have a full schedule, but hope to be able to answer as many questions as possible. Now let's get to our conversation. The first topic we're going to talk about involves community needs and how we prioritize those needs. Hospitals provide more than just healthcare. They're often anchors in their communities, providing jobs, driving the economy, and partnering with local entities to make community members healthier. Besides being the go-to source for healthcare, what role do hospitals play in their communities with respect to creating or improving health, and why is it important for hospitals to be involved in their communities? I'm going to start by calling on Chris Lumsden from Mount Airy at Northern Regional Hospital. Chris?
Well, thank you, Patrick, and good morning, everyone. Our approach here at Northern Regional Hospital is to be engaged in all areas of community life. We recognize, like most hospitals, that we are the largest employer in the city of Mount Airy and one of the largest in the region. And as such, we need to take a leadership role in many aspects of our community, from K through 12, public education, to higher education, to economic development. So these are roles that we play, recognizing that if the hospital is healthy, the community in a rural community will be healthy, and vice versa. If the community is healthy, the hospital may be healthy as well. So we've taken a very strategic approach to being engaged in the community, and from a leadership perspective, and providing resources, if you will, to make sure that, again, education, economic development, and our industrial community is strong and healthy as well. So leadership in the community is really paramount for our organization.
Absolutely. Thanks, Chris. Someone else like to chime in?
Yeah, Patrick, this is Penny. If I might add to what Chris just said, completely agree with everything he said, but I also think that in rural settings, hospitals play a part in community resilience. It's kind of recognition of that link between rural healthcare and economic strength and overall vitality. In rural communities, healthcare and that overall vitality are kind of intrinsically linked. So a robust community supports and sustains quality health and social services. It does that by, attracting well-trained and committed healthcare professionals. But communities with strong economies, they're more likely to financially support their healthcare system. And whether that's through philanthropic giving or investing in the infrastructure, can be leveraged by the healthcare system. But in return, then the healthcare system can support economic and community development initiatives. So, together that really equates to really ensuring that community resilience going forward. So it's kind of this perpetuating feedback loop.
Absolutely. Anyone else?
Patrick, if I can jump in,
Sure.
I agree absolutely with Chris and Penny. A couple additions I would make to that is, when we talk about being one of the largest employers, part of that economic driving aspect is how we treat our employees. If we're paying them well, if we are the ones driving to make sure we're paying an adequate minimum wage and that we're paying great benefits. Those are things that just translate further into the economy, for everyone else that lives here, including our employees, but also looking at other employers in the community that then say, hey, we need to be competitive. And so, it allows everyone to work toward competitiveness. The other direction I would take on that question is just thinking about all of our organizations have great mission and vision statements. They're all different, but I guarantee you they all drive toward, just ours is guiding our neighbors to optimal health. And everyone, while it's worded differently, is doing the same thing. And we recognize we don't do that in our bricks and mortar in one location. We do that throughout the whole community, and we do it based on the needs of each part of that community.
Thanks.
John, that's a good segue. If I could add, from our perspective, I love this question, and especially the part about why is it important. So, like you said, in addition to the work we do to help people from caring for injuries and illnesses, we go beyond the hospital walls with our community approaches, and not just because we serve the community, but because we are the community, to your point, right? We have people, as one of the largest employers or the largest employer in all of our communities, we have people who are parents in the schools, coaches, they're going to churches, they're going to local restaurants and grocery stores, and they see and use the resources that is the fabric, the tapestry really of our community, and each individual from our meeting rooms to our front lines and patient care rooms is pulling a thread of that tapestry through in their everyday lives. So creating a culture that has that perspective and value at the center drives our decision making, and it drives our strategies and where we can show up and how we support our colleagues in being part of the community.
Thanks for all your responses. Great start to our conversation. We have a saying across 36 years of our work at the North Carolina Rural Center: when you've seen one rural community, you've seen one rural community. And that is a statement that certainly resonated with us over our years of working in rural communities. Every community is unique, has its own set of challenges. How does your hospital identify the specific health needs of the community? How do you use this information to develop initiatives to address social, economic, and environmental issues that your community faces? I'm going to start with Todd, and Todd asked you if you could talk about ECU's new lifestyle medicine clinic and how the program was designed to meet the specific needs of each individual patient.
Yes, thank you, Patrick, and thank you all for participating on this panel. And I certainly am with an esteemed group of folks today to help describe our approaches to rural health. As it relates to the lifestyle clinic, that is a great program and largely focuses around some of the chronic disease management, and that really stem from more of overweight or obesity kinds of models. And it's a great program because of the patients it serves, clearly, but our approach more, and especially from a rural health perspective, is how do we integrate with interventions that we know we can standardize and that we can create options for primary care services to provide the same service at the high level of quality and intervention that improves health outcomes. And we have lots of data sources and mechanisms for achieving the data pools, but then how do we set care pathways and standards of care that we know um, that can be implemented at each clinical area, each primary care level that goes closest to where these communities are and closer to kind of the upstream care of getting early intervention for people with disease. And so the lifestyle clinic is a great model because it's a test of change. It's a pilot. It can try interventional approaches that, when effective, we can then replicate throughout our system. And then that replication allows the standard of care to come up to hopefully improve the overall health of the communities we serve. And I think getting back to your first question about how do we continue to evolve and improve rural care, one of the things that we have at our advantage in rural care is that we don't have the same type of competitive model, right? We don't necessarily in these rural areas have, you know, two hospitals right down the road from each other, you know, trying to compete in those ways, right? And in rural area, if there's advantages to it, it's that we can focus our time because we're generally the source of healthcare in that community. We are the largest employer and the source of care. So that allows us a great framework to partner with community organizations and other social services to help align a standard of care within their world, within their care, within their services. And that synchronized model, that symphony of care, I like to think of it as, is kind of where we try to develop that across Eastern North Carolina, and partnering with a lot of great people on this call to hopefully do that better than maybe other parts of the country are able to achieve.
Great point, Todd. John, can you discuss how the new Iredell Urgent Care in Statesville is catering to the community's needs by staying open later than the other urgent care facilities in the area? And why is it important to tailor our healthcare delivery approach to meet the needs of that community?
Absolutely. It's a pretty unique situation, actually, and a little bit contrary to Todd's description of not having competition. We actually did have two hospitals in our community, and then the end of last summer, the other hospital closed. And so overnight, we had to figure out how we were going to handle a significant increase in volumes in some places. Probably the biggest being, you know, that other facility had 20,000 plus emergency room visits per year. You know, so we did a couple things. You know, one, we obviously had to increase our emergency department staffing ASAP. Secondly, we altered a building project that was going to be for the intensive care unit, and we made it intensive care unit and emergency department because we recognized that we were going to have to handle that increased volume. And that's kind of a precursor to my answer. So my answer then is, you know, how did we then build the urgent care? Was we recognized, you know, several things. One, how do you offload some of the emergency department volume? We all know a lot of the patients that come to an emergency department don't need emergency level care. They need care now. You know, and so the goal was, how do we look at that? Secondly, a lot of folks don't have primary care physicians. You know, it's a staggering number. You know, I always think, oh gosh, that we're going to solve that next year. You know, next year hasn't come yet. You know, we still have a lot of individuals that don't have, you know, primary care. And so that led us to say we need to do an urgent care here in Statesville to help with all of those reasons. And additionally, put it somewhere closer to the other hospital that now is closed from an acute care standpoint, so that we could get folks that were accustomed to going to that side of the community care. To the hours standpoint, no one can plan when you have an emergency or urgent need, first off. So when it's a higher level need, it happens. Secondly, we respect and we looked at our community and said, how many folks are working and can't get during normal working hours to a facility for care? You know, in the southern part of our communities, you know, Mooresville, we added a 24/7 urgent care. You know, for the exact same reason, we recognized that people needed options. Statesville being slightly smaller than Mooresville, we decided, you know what, we're going to go with a 7A to 11P. And we decided to look at that and say, will that be successful? And I'll tell you, in the first 4 months of operation, it's been extremely successful. And most of, you know, more of the work has been at off hours. And we've gotten thanks left and right because of the fact that we are looking at, working to be consumer centric, looking to when that individual has the opportunity to get to the care, not when we're driving them to the point that this is when you're allowed to come. And so, I honestly drove by this morning at about 7:15 and there were 4 cars in the parking lot, of customers. And so, that shows, trying to look to the consumer's need, not our preference necessarily, but their need, because that's what we're here for, is definitely what is going to drive and should drive the best decisions by our organization.
Patrick, may I add a quick story?
Please
An
do.
example. Last spring, we made a decision that the executive leadership team of Northern would make visits to industries, and the industries 10 were very welcoming to us. And we spent 3 or 4 hours visiting their facilities, meeting with the executive leadership team, and of course, focusing on healthcare needs. One of the industries located about 10 miles from Mount Airy and Dobson, which is the county seat, 40% of their employees are Spanish speaking, which is reflective of the population of that area. And it was indicated to us that the need for primary and family medicine in the community, because not all of the community and employees could travel. So within a year after that visit, we opened a family medicine clinic in Dobson. We had 250 people show up for the ribbon cutting ceremony, and we employed 2 providers, both bilingual, to provide the healthcare needs of that community. So the point isn't just primary care, it's the ability to move quickly to meet the needs of the community. And so far that project has been very successful.
Thank you, Chris.
Patrick, if I could add another trite saying, which is that healthcare is local, right? But so I'll just, when you look at tangible things that can inform, what in your community is very unique and how you, with its own set of challenges, how do you identify those needs? The very tangible thing is the community health needs assessment. But I will tell you that we probably focus more on a great asset, which is listening to the community's collective voice. It's represented in a number of ways, but it could be the patient and family advisory councils that we have, or a really valuable indicator is often the emergency department, who and what is coming in through the emergency department. So patterns of needs beyond like direct healthcare needs are typically revealed pretty quickly, whether it's food insecurity or homelessness, substance abuse issues, things like that, or even perhaps the need for child advocacy. But you see that. And then when it comes to being relevant and remaining relevant, I'll tell you, I will confess, I shamelessly steal from other hospitals and communities where initiatives have been successful. So Todd and John and Chris, you may get a call from me soon. Thank you.
Let me move us along to our second topic area, collaboration and innovation. We all know that hospitals collaborate with community partners to improve the health of communities. Can you discuss a few key community partnerships or collaborations that you believe have been particularly successful in improving the health of your community? And Chris, I'm going to come back to you. What successes has Northern Regional Hospital seen by participating in career development programs like Camp Med and partnering with entities like Surrey Yadkin Works? Can you talk about the benefits of these programs and why it's so essential to train the next generation of healthcare leaders?
Yeah, that's a great question and an important theme for Northern Regional Hospital. Just a couple of statistics, not to bore you and the audience to tears, but I asked our Human Resources Department what percent, this a couple of years ago, what percent of our employees were raised and live within a 25-mile radius of Mount Airy. And this is probably the case for other rural communities. 85% of our employees. And also 85% of high school students that leave the high school for work or for college outside our region do not return to this area. So the message is we have to grow our own, and that's a theme that we have created through education assistance, scholarship programs, nurse internship programs, and the list goes on. The two that you just referenced, the Camp Med is one that we partnered with the Northwest AHEC program, and that is offering students the opportunity, high school students, primarily juniors and seniors, the opportunity to work 40 hours, that is 1 week, in a hospital in an organized fashion with a number of different teachers and hospital leaders to get hands-on experience about what goes on in a hospital. So we did that last year. We had almost 20 participants. This year, we hosted it. We had 2 different weeks with approximately 40 to 20 in each of the classes. And it's just an outstanding response from the students, and gave them hands-on experience, taught them a little bit about healthcare, and it just started that pipeline, if you will, of interest in a profession in healthcare. So that was the Camp Med program. Suryakin Works, you can Google it. It's been just a tremendously successful program. We started in January of 21, so we're entering the, if you will, the 3rd year. It's an apprenticeship program, a pre-apprenticeship program. It's one of the first, if not the first, in the state of North Carolina. Healthcare represents about 50% of the apprentices, which are about 50 each year. And it's just a way of introducing high school and first-year college students, primarily community college students, to the healthcare profession by giving them the opportunity, 1, to work in the hospital setting, 2, to be paid while they're working, 3, to get high school or college credits at the same time. You can't get better than that. And it's a collaborative effort between 2 county governments, 4 school systems, hospitals, and the private sector as well. So again, it's just an example of creating the pipeline for keeping young people and older people in our community to work in healthcare, and hopefully within our organization.
Thanks, Chris. I love it. That's fantastic. Todd, ECU Health Roanoke Chowan Hospital recently awarded 13 local programs $95,000 in grant funds through its Community Benefits Grants program. Can you talk about why it's important for hospitals to support community organizations such as these 13 local programs, and how that leads to better health outcomes for residents?
Sure. And and again, taking advantage of where we have opportunity for funding where we can. And so we do a lot of work to really assess where and how we can invest back into the communities. And we see that as role of a good steward of healthcare in a community, but also recognizing that it's our partnerships that really connect our services to our patients, and if you will, our population. And so while we all depend on hospitals and health systems to provide sick care, the challenge is how do we provide health care? And with a healthy patient population, you receive or they receive more services upstream from where they would get the sick care, and then avoid high cost places like the emergency department and unplanned admissions and otherwise. And so we implemented through our philanthropy and our foundation an approach to try to help support those systems or those community-based resources that are most connected to us in that endeavor. And so that helped outline really a lot of great programs that we could help with some funding that they needed to help further take care of our patients. And we're seeing a lot of great traction with school-based programs, and this particular program really helped connect to our schools to also help with healthy living and those educational opportunities that can exist within the school system. We also use our population health services, and that's where it's more of a contract for services for an employer or a payer group to help identify where and how we can improve the health outcomes of a defined group of people. So there's aggregate, and then there's names on a list. And so we engage in both models from a community health perspective and what we call a population health, where we define clear care outcomes, and we employ models for screening, early diagnosis, care management and care coordination of services. You can imagine in rural health with all the transportation issues and health disparity issues you can you can point to. Having that connectivity with real people who understand those models and can help them access services is a big deal. And both avenues, from a community health and a population health perspective, allow us to have a multi-interventional approach to how we improve the care in these communities.
Thanks, Todd. In the interest of time, I want to ask a really specific question to Penny. Blending innovation in terms of thinking differently and creatively about problem solving with technology can drive unique or creative approaches to programs and initiatives. And so I want to talk to you about an innovative program that's been particularly successful. Penny, I understand that Onslow Memorial Hospital has several initiatives under development that capitalize off the functionality and utility of telehealth. Can you tell us more about this and why it's important to continue to develop innovative ways to bring healthcare to community?
So I'll discuss a little bit about the fact that I am a huge proponent of regionalization. I actually believe that this is kind of a next generation collaboration and innovation, in that we view the provision of care from a regional perspective. And if COVID did nothing else, it demonstrated to us the functionality or the utility of telehealth. So within regulatory parameters, it may be possible to provide quality healthcare to a region versus a single hospital. We recently began work with, we're in a partnership with UNC Healthcare, and they're incredible partners. We have a management service agreement with them, but we began this work to provide pediatric telehealth coverage that would lay the foundation for regional coverage. Additionally, we're looking at a palliative care program where an advanced practice provider would cover the program regionally for 2 rural hospitals who otherwise wouldn't necessarily have one. So I think looking at telehealth as a means of providing services where you might not be able to support is a great way of really thinking outside of the box and using innovation in terms of telehealth to make things happen that wouldn't happen otherwise.
Thanks so much. Jumping forward as we're needing to close out this segment to topic 3 and really looking towards the future, we all know community needs are constantly changing. What steps does your hospital take to ensure your programs and initiatives are evolving with the community you serve? And are there any new directions or areas of focus that you'd like to highlight? Annie, in particular, I would like to ask you about programs providing medication-assisted therapy to combat overdose deaths from opioid misuse and how those are gaining traction. Can you describe Mission Health's role in this initiative and talk about how the program has evolved?
Yeah, certainly. That is a good example, I think, of how, as a hospital system, we have been involved in the conversation and the treatment of the response to the opioid epidemic throughout its entirety, not just from recognizing the need as it comes in the acute moments in the ER, but to the long-term length of stay from endocarditis and the impact that has on the capacity and volumes in our hospital to care for all of the acute needs that come in. So just as an example, there is a hospital perspective that we have that is important, an important piece to that complex puzzle for community in addressing and providing care for those dealing with substance use disorder and the overdoses that we see. And so we've been at the tables with public health, with with law enforcement, with the whole system at large, sounding the alarms that everyone has been sounding that we see, right? And the community has been working together on responses at such a rapid rate to save lives. And we've reached a point where we are able to participate, our EDs are able to participate in a pilot that is just beginning, where we're able to activate the medication-assisted treatment in the ED at the point of care and become a new access point for patients to receive this evidence-based, much more effective way of intervening in the addiction cycle while they are with us, either for that overdose risk, or if they come in for other reasons and share that addiction is part of their health struggle, we can activate it here and then refer to community partners such as our Area Health Education Center, MAHEC, who has waiting appointments for our patients in quick response. So working with community care paramedics at our county level, we have our flagship hospital here in Asheville, but also our Blue Ridge Regional Hospital in Spruce Pine are 2 of 8 hospitals participating in this pilot. And it's just kind of shows how we've, like I said, been at the table. We've all seen the need. We've been personally impacted. We have people on our clinical teams who have lost their own children from this crisis. So we've been looking for solutions, educating our care providers on what to look for. But to have this new phase of the process and treatment and care, it not only it's a wonderful point in time, and we're excited about where it's going. And it is something that all of our partners in the community have been eager to see as well. So I think that's something we're looking to see advance as well.
Thank you so much, Annie. This has just been a great conversation. And I want to move us along to some Q&As that have been pre-submitted from the audience. And just feel free, jump in and chime in on these. From Julie in Greenville, how can rural health equity initiatives be accelerated through research and policy advocacy at the state level?
Well, I think I can start on that.
Sure.
I think, one of the most important challenges, I think, for any organization our size is funding. We don't have unlimited funds. We don't have the ability. I came from a large hospital up in the Midwest down here, and I remember the CEO at the time I came said, we can't make 7-figure mistakes. Where you came from, maybe you could. We can't. And I think when you start talking about research opportunities with funding that will take us from a trial and error approach to a more defined, this worked approach, kind of to Penny's point previously about stealing from each other, that gives us a great opportunity along the same line to do that. So I think, research that allows us to see, hey, this is going to work, or we believe this should work, is a huge difference to us.
Right. Anyone else want to chime in? I'll move to the next question. Greg from Chapel Hill, what are some of the strategies used and areas of success you've had to improve health outcomes longevity in your communities?
Patrick, if I could
Sure.
answer that, that'd be great. So I think some of the tactics that are used really, I'll reference the Dix Crisis Center, which, that was a tremendous community effort. And I give all the credit to the county who spearheaded that. But we brought in several different counties. It wasn't just Onslow County, it was Carteret County and Craven counties, along with Carteret Healthcare. But the Dix Crisis Center opened with 16 beds. Very successful, but 16 beds. And it was to address, mental health, behavioral health, substance abuse. It really was to ensure that patients who were in crisis were, received the care they needed right away. Terrific, great. Upon discharge, theoretically, a patient set up with outpatient follow-up to continue treatment and support. But what the success of the crisis center actually resulted in, kind of inadvertently shining a spotlight, revealing where we had voids in services across the continuum. So I think to ensure that there's success as you implement some of these very highly successful initiatives is to ensure that you look across the care continuum. Because as we have success in this one piece of it, and I would never change what we've done, the crisis center is highly successful, and it does deal with those patients who require some assistance acutely. When the outpatient resources, when there's a dearth of services there, then ultimately you have a kind of a vicious cycle where they're just then coming back to the emergency department if they don't have the resources on the outpatient side to continue to improve and seek treatment out.
Great example. So here's a question from Garrett in Charlotte. It's kind of close to my heart, given the one of our big focus areas at the Rural Center. How do you see the adoption of technology impacting rural communities? How is it different from or the same as urban areas?
Yeah, maybe I can weigh in on that a little
Go
bit.
ahead, Tom.
I think when you think about it as how does technology and improvements in care continue to progress? One is, I think, with virtual care and telemedicine would be an example. And I think from metropolitan to rural health, the technology would be very similar, would be the same, but the adoption of it has to be very different. And so I think in more metropolitan areas, just access to internet, broadband, those kinds of issues are less of a barrier than they are in rural areas. And so for us, I think in rural areas, telehealth, first of all, a national model for rural healthcare is going to have telemedicine, right? It's going to have that as a core component of it. But where and how it's implemented among a patient population that struggles in that is the challenge. And so working with our civic partners, working with counties and townships, trying to build out and create the funding both through grants, through alignment of federal funding as well, to help expand that is a big deal. And we as healthcare leaders have got to have a voice in that, and we have to continue to push forward. And the whole idea for all of it is getting us far up for early intervention and early detection and early changes in behavior that can impact that downstream crisis management. I think to the earlier question around longevity and things, I don't know rural health is extending longevity as much, but more so it's in terms of the quality of life that they can have in that time period. And the aged population is going to continue to grow in rural areas. So now how do we continue to help engage with them so that they are getting the right care, avoiding again the emergency crisis management models? And I think technology and telemedicine, those things are going to be the key.
Patrick, can I briefly add on to what Todd just said?
Yes, please.
Because we utilize telehealth to a certain extent, to his point that it's different in a rural setting than it is in urban setting, our telehealth apps or applications that we employ or programs that we've developed around it are hospital-based. So we don't reach out to the community. They're hospital-based programs that connect with another hospital. So the bandwidth is there. But for example, a hospital at home scenario where you're connecting with patients who are at their home and your success is contingent upon their bandwidth, likely the circumstances or the success of a program like that, you'd have to research quite a bit more.
And I would add to Penny's that it really, well, I'm sure we've all found the same thing. Even across our own service areas, it's not the same from one part of the service area to the next. Right. And so much of it is bandwidth driven. Some of it is just generational training. As Todd mentioned, the folks that are in need are necessarily not the most tech savvy individuals. Heck, I'm not the most tech savvy individual. I'm just happy that this Zoom's working for me right now. But the reality is that when you're in a larger community and urban setting, the opportunity to have a large group of individuals right near you to assist you in that training and in that opportunity is there, where when you're out into a rural community, it's not always as convenient. It is more difficult.
Let's move on to a fourth audience question. Vanessa from Hubert. How do you collaborate with nonprofits to improve access to care for our most vulnerable citizens?
Patrick,
go ahead, Chris.
I'll take a quick crack at that. I'll just give one example. We introduced a ambulance or patient transportation service last year We have a fantastic EMS program here in Surrey County, but they were overwhelmed. And we were finding that many of our patients, whether it be inpatients or in the emergency department, just did not have transportation services. So they would linger unnecessarily in the hospital. So we decided to create a patient transportation service, and that has been unbelievably well received. We can now get patients to their home, patients to a nursing home, patients to a medical center much more rapidly than we did yesteryear, matter of hours versus in some cases days. So this is just an example of listening to our patients, listening to our community, being creative and establishing a service that has really helped, whether it's upstream or downstream, patient care.
I just wanted to kind of go back to a comment about our approach at the beginning in terms of the starting from within and kind of using the experience and wisdom and voice of our colleagues internally, because they are connected and passionate about different causes and exposed to different communities by their own network of understanding and relationship. One of the ways that we connect to and support and encourage or incentivize really that feedback about need and impacting communities is through a culture of giving and volunteerism. And I know that as anchor institutions, we are all engaged in that way. And what we see is that by supporting board leadership and having individuals connected to nonprofits in terms of adding a subject matter expertise or liaison to the hospital, but also deeply understanding the work of our community partners in the nonprofit sector allows us to take that wisdom back, to bring it to policy discussions, to connect with our, public health leaders really are an incredible partnership to our hospitals for understanding what perhaps hard to reach communities or those with medical mistrust are experiencing, and so that we can look for those open doors and avenues in, meet with those gatekeepers for those communities, adjust our approaches. And not only does it help us be more responsive within our walls when they come to us, but then we are also active participants on, forums, on community panels like this one, but also in task force developed by civic participation to then impact and drive up legislative changes even. So it really is a hyper-local response that has a whole continuum of areas of impact that we participate in, from showing up and making sure that the kids who come in through our pediatric have access to clothes and backpacks, but also then that we're taking the feedback from those who've been involved in our SANE nursing program to modify the environment in our compassionate care unit for those forensic exams, to really working together with all of you on this call to get Medicaid expansion through so that we can increase access to care. So it's been folks from the local, hyper-local communities who have voiced the need by which we can then modify all parts of our system.
Question from Cynthia in Raleigh. How do you involve people from the community to identify healthcare needs and upstream opportunities to improve health? Anybody want to take that one?
So,
Todd, please.
So part of it is I don't think there's any one way that get that information accomplished. And I think that's part of our multifaceted approach that every health system represented on this call has to engage in actively, to continually pursue the changing and understanding changing environment of our communities. And so whether it is with the partnerships that we've discussed earlier on this call with community organizations and other social services and those endeavors, whether it's community outreach where we are doing, I think Penny mentioned COVID and how much that kind of progressed our community efforts forward. Well, most of us have held on to some of those key interventions and lessons that we learned during that time and only made them better. And now have more hardwired interventions in those communities where we have outreach, where we have liaisons, where we involve church leaders and faith-based community into our system. And we have regular meetings that bring them to the table to understand how they want to receive care and how they want to stay healthy. And again, it's that migration of being a sick care system to a healthcare system. To me, the community and engagement is where that happens. And cultural alignment, diversity, equity, inclusion, these kinds of themes and schools of thought, that's where it's lived. It's where you're going into the community where people live, where they worship, and to find out how we can engage with them to keep them healthy. But that's just an evergreen kind of model. You have to just continually be working at it.
Great, John. John, do you want to add something?
Sure. I think a couple things. Penny previously mentioned the community health needs assessment. That's always an important aspect, that you're getting input that is kind of a little bit more of a formalized way. But realistically, Todd described it well. I mean, this is one of the hardest part, but most important part of our jobs. It's not to get, mired in the operations where you don't get out of the building, but you need to leave the hospital and you need to be out in your community. And I think in a smaller community, we have a better way of doing that possibly because, we interact with so many people and people know who we are. But that's a hugely important part of it. At Iredell, we also have kind of a unique situation. We have a board of directors, the individuals that manage the organization, but we also have a board of trustees. And that is a group of 160 to 170 individuals who we get together on a basically quarterly basis, and we ask for their input. And so they're intentionally picked to be a diverse group of individuals that have to reside in our county. So, we basically have a group of, on the right hand, cheerleaders, but on the left hand, folks have recommendations and suggestions that we're asking for their ongoing input. And so I think, whether it's a formalized way or not, any way we can get to the different groups of individuals frequently is really the key.
Great point. So here's a live audience question, a great question, and it takes us in a little bit of a new direction. What initiatives have been successful in communities where cultures are mistrusting of hospitals or healthcare workers, where that relationship of trust with a specific community has not necessarily been built?
Well,
for us, we went, I think going back to COVID was probably a time that improved the situation some, but we went through the faith-based organizations. And that's what we still continue to do, recognizing that those faith-based organizations are very local to each community and to each group of individuals in that community.
Chris?
And the only
I was just going to say, this may be stating the obvious, but some organizations are inwardly focused on operations, some are outwardly focused on the community, and then the best are really focused on both. We as an organization have really created a culture, not just of the CEO, but the entire leadership team and all of our teammates to be engaged in the community. And the best feedback that I think we receive is the feedback in person from our patients and from our community residents, from our industrial or industry partners. And they, if they trust you, they will tell you what they think. Most of the time it's good, but every once in a while it's constructive criticism, and that's fine. But what we found is the more engaged we are in the community, the more good feedback and the more timely and the more relevant feedback that we get regarding the services that we're offering, or perhaps services we're not offering that we should. So that's just been maybe a philosophy that we've maintained here at Northern Regional Hospital that I think has produced some good results.
Completely agree with what Chris just said. We have a culture at Onslow where I've encouraged the staff to act as ambassadors. That's internally and externally. So you're going to do that for your coworkers. You're going to do that for your teammates. You're also going to do it out in the community to act as an ambassador for the care that we provide here. I also think that giving back to organizations in your local community, and they may be healthcare associated, they may be other healthcare institutions, but giving back to other organizations within your community helps to build trust. So it's multifaceted, but I do think it starts with culture.
I love those comments. Thank you, guys. That's exactly it. And I think that's the purpose of having this panel today, because we understand that that the entire need is to have that trust between provider and patient, between system and community. And you got to show up, you got to pay attention, you got to listen, and you have to give it time. Sometimes you have to repeatedly show up in ways that are helpful, right? And that's by joining the people where work is happening, looking at what they are doing and offering something of importance and value to that effort, whether it is standing side by side with other folks in a food bank and preparing food for delivery, or whether it is sitting around a conference table and figuring out how we are going to address, the sudden increase in a particular, public health epidemic that we're seeing. You build trust over time by repeatedly showing up.
Thanks, Sam. So our time has really flown by. It's a great conversation. I do have a final closing question I'd like to invite all of you to answer. And you may be inclined to give a complete dissertation, because I can imagine you've got some really great stories about what led you to your career. But that is my question. What really led you as an individual to a career in healthcare? And Chris, I'm going to start with you.
Basketball. When I was a junior in college, I played college basketball. A junior in college, my father suggested I consider hospital administration because he knew the local hospital CEO. I had no clue what he was speaking of. So I met with him, and he hired me as a summer extern because the CEO had 4 young sons who liked basketball. So I was the connection there. When I finished college, he hired me as administrative assistant for 1 year, contingent on that I play on the hospital's industrial league basketball team, which I did. So that was my introduction to healthcare administration. I went on to graduate school, and the rest is history. So basketball, probably the connection.
John?
Sports is also the connection, although I wasn't on the hospital team. When I was a high school athlete and had multiple knee surgeries, and with that I had to go to physical therapy. I don't have any healthcare individuals in my family, and what I learned from going to PT was I loved the helping and caring aspects of it, and so that made my decision. I went off to physical therapy school. Love the aspect of every day being a different day, working with different people with all the different needs and the different levels of needs. After a number of years in PT, I actually recognized that I could, I was loving helping one patient at a time, but as I moved into leadership roles, I could help more than one patient at a time. I could ideally help a community at a time. And so, I transitioned from a PT to administrator, more from a clinical route, which has been, absolutely rewarding.
Penny,
Have you read the book, The Five People You Meet in Heaven? It's a great book. It's a quick read, but it made me reflect on things a while back. And I'll tell you that I do have an answer to this, because who has had an impact on your life? And I would have to say there are two individuals, and one is my mother-in-law. She wasn't my mother-in-law at the time, but she was a great lady who was a psych nurse. And I truly wanted to emulate her growing up. And we knew each other since I was very little. But so definitely one of the folks who had an impact on that decision making. But what got me away from the bedside was Dr. Ed Piper, who was the former CEO here at Onslow and a great mentor. And he just encouraged me to move forward with leadership roles. And I continued my education and serendipitously found my way here. So, but those are the two people I attribute that to, that whole decision making, but all of them had the deep desire to serve others.
thank you. Annie,
So my path to Mission Health really came from a career in, I would say, social determinants of health before it was really called that, and working on my direct service work was navigating patients, case management, and then I worked with the North Carolina Medicaid system through community care, the community care model. And so throughout my career progression, I not only worked with people on individual levels and kind of saw the need, helped find solutions to the need, gathered resources, but increasingly worked in cross-sector ways with government, with nonprofits, with health systems, to sort of envision how we close gaps in care, how we create systems that work for more people. And so mine was kind of a progression from individual frontline service in a complex system to being part of that system, really, and trying to influence and support that system and being more accessible to all people. So I agree with everyone here who has experienced the service leadership call.
and Todd.
Yeah, so maybe similar to John, when I graduated from college, I was a speech therapist and worked in a school system as my first job. And you know, I coached every team they had and refereed every game and all those kinds of things while I was in school, but really just had a passion for healthcare and helping others. And through a series of chain of events, I ended up doing a lot of work out of the school board office instead of in the clinical world, and they had other people help and take care of those needs while I worked more on administrative work. And there was a push to go into school administration and things, but I knew I needed to be in healthcare, and so I ended up getting a master's degree in healthcare administration, and I've really worked in administrative roles for 25 years now. So
We're thankful for the career trajectory of each and every one of you. So it's been a pleasure getting to know you and spending some time with you. That's all the time we have, and I'd like to thank each of our panelists: John Green, the President and CEO of Iredell Health System; Todd Hickey, the Chief Strategy Officer for East Carolina University Health; Chris Lumsden, the President and CEO of Northern Regional Hospital; Dr. Penny Burlingame Deal, President and CEO of Onslow Memorial Hospital; and finally, Annie Carpenter, Assistant Vice President of Mission Health. Thank you all. And thank you to all of our audience. If your question was not addressed today, please send an email to communications@ncha.org, and the Hospital Association will reply back to you. A recording of today's conversation will be available for viewing or listening at nchealthcare.org. Feel free to share the recording with coworkers, students, and others. Again, that website URL is nchealthcare.org. My name's Patrick Woody with the North Carolina Rural Center, and thank you so much for attending.
Thank you. Take care.
Thank you.